Recording in progress.
Good evening, everyone, and welcome to the 27th episode of e-Gurukul series of surgical skill transfer and solving the clinical dilemmas by a distinguished gynecologist and a passionate teacher, Dr. P.C. Mahapatra, sir. So, if you have missed the previous episodes, we have started a channel, a YouTube channel, and the name of the YouTube channel is e-Gurukul by Dr. P.C. Mahapatra. So, you can watch all the previous episodes there and also subscribe the channel so that the new notification, you will get automatically the new notifications. And today's topic is also very interesting. The today's topic is genital malignancy, ovarian cancer, and surgical options, tips and tricks. So without much time, I will hand over the session to Dr. P.C. Mahapatra, sir. Please, sir.
Thank you very much, Sanjay, and the whole team of Juventus for again continuation of these episodes after episodes, and we are reaching now the 27th episode. Well, on behalf of Juventus, also on my personal behalf, I welcome all the delegates, my viewers, my gynecologists across the country and abroad for this educational initiative taken by Juventus for the last couple of episodes and particularly over years. And today we have reached the episode 27. Here again, as usual, the theme is on surgical skill transfer, and a particular focused subject today is again one aspect of a genital malignancy is ovarian cancer. The 26th episode is also dedicated for the malignancies, but we have dealt with the uterine and the cervical cancer in the previous episode. To complete the genital malignancies, I think it's better to complete it by adding ovarian cancer into it. And today I thought that this episode will be strictly confined to the ovarian cancer. And at the outset, I must admit that I must give a special thanks to my oncologic friends here in the Acharya Harihara Institute, the whole team, including my friend Dr. S.K. Giri and the whole team, my students who have become teachers now, excel themselves in the field of gynec oncology. And by virtue of being a teacher for the last 40 years, I was not very much interested in oncology, but as a teacher, I had to do something spare on oncology and that. But some additional tips I have brought from these London malignant gynecologists under the leadership of Dr. S.K. Giri. Well, I bring greetings from the place of Lord Jagannath. And as usual, we'll focus this particularly on ovarian cancer. Believe me, if you may not be an oncologist, but I think as a basic general gynecologist also, everybody should know about the basic aspect of ovarian cancer, genital malignancy in general. And the fundamentals of this will not only enrich them of updating their knowledge, but in day-to-day practice also, they have a very important role. Although the domain is primarily now with the era of subspecialty, gynec oncology has really established itself as a distinct subspecialty by itself, not only in India, but the whole across the globe. But I must admit again that the role of general gynecologist is of profound interest and of paramount importance for that. Because the coordination has to be done from the general gynecologist, and the consultation of the gynec oncologist is necessary in special situations for that. And therefore, particularly when dealing with the subject of ovarian cancer, it is a must and mandatory that the opinion of the gynec oncologist is very, very helpful. But the basic diagnosis, the early diagnosis, the clinical examination, and the investigative and the surgical aspect also, every gynecologist should know this. And that's why, for the benefit of the patient, they can take help of the super specialized gynec oncologist, which also I do at this state also. I really take help of the gynec oncologist when it is necessary for that. And I hope that they will do better job than myself. These are some of the hard facts regarding carcinoma ovary. Ovary is a very peculiar organ, a small organ responsible not only for reproduction and the continuation of the human race, but production of the hormones to have a not only a mother's hormone, pregnancy hormone, and feminine forever. It has a tremendous impact from puberty till menopause and even after. And on the other side, it also is a reservoir, as a source of malignancy, not only originating from the ovary, but also it's a very good receptacle and very good station for the other malignancies for secondary deposits. So ovarian cancer accounts for more deaths than any other gynec malignancy. As far as the incidence is concerned, it might be ranking in the lower order in comparison to the cervical or endometrial. But as far as the mortality is concerned, it is highest as compared to the other genital malignancy. This is a very, very important thing. One must understand that. And when we come to the statistics globally, around 2 lakhs 95,000 women are diagnosed, out of which approximately 2 lakh or 1.85 lakh women die from this disease. It is a recent statistics by Bray 2018. So highlighting the mortality of this dreaded disease of gynecological malignancy, the ovarian cancer, everybody should be concerned about that. And epithelial ovarian cancer accounts for 90% of the cases, and therefore exhaustive studies, literature, research work, as well as the different changing trends in the therapy has been focused mainly on epithelial ovarian cancer. It presents major surgical challenge, requires intensive and often complex therapies, and is extremely demanding of the patients regarding the psychological and physical energy. And therefore, things have changed. The technology has added to it. The conceptual understanding has changed. And therefore, it is not like the yesteryears. The survival rate has dramatically improved because of the changing skills and acquired skills of the neurodevelopment in the science regarding the skill, surgical skill, as well as the medical management or medical oncology, which has taken a great part in that. Approximately 80% present in advanced stages. That's the peculiarity of ovarian. In contrast to cervical or endometrial, which I've already told, in early diagnosis, we can do it in other cases, but here, the peculiarly, by the time they present in advanced stage, 80%, but 20% can be diagnosed in early stages. One of the peculiarity here, we know that the carcinoma in general malignancy is a disease of the related to the ears in the late age. But this is a disease where ovarian malignancy can occur in the two extremes of age, in adolescent as well as in menopause and post-menopause. An adolescent malignant ovarian is really a surgical challenge. The young girls of 14, 15 and suffering from adolescent malignant ovarian, particularly the germ cells, tumors, the teratomas, the dysgerminomas, the embryonic carcinoma, all these adolescent malignant ovarian cause really a surgical challenge again and leads to a greater mortality. The diagnostic pitfalls are common in ovarian. The screening is an enigma. The screening is a very, very clean-cut and strategic in a case of carcinoma cervix or carcinoma endometrium. But as far as out of all the genital malignancies are concerned, screening is really an enigma when we think of ovarian. There is a changing concepts regarding genesis. I will deal with the pathogenesis. I will tell how the changing concept and genesis. And one of the very important messages today I will give, that yesteryears when we were teaching about 10 years back, for years together, we are teaching ovarian as a separate entity. Now the changing concept that ovarian, tubal, and peritoneal happens to be a common spectrum. Now you find in recent books, you find not only ovarian, wherever ovarian is there, they write ovarian, tubal, and peritoneal disease and malignancy. And that's the changing concept. And that gives us an idea that the pathogenesis could be common, the cause could be common, inciting factors should be common in these three entities. Well, one of the very clean-cut understanding by researchers is attributable regarding ovarian malignancy is a familial and hereditary basis, genetic basis. This is very, very important. This is known, but the rest is not known. And here in a case in carcinoma ovary, it's not the surgery alone. It needs a multidisciplinary approach. A multidisciplinary team is necessary with the gynec oncologist, with the surgical oncologist, with the radiotherapist, with the chemotherapist, and they form a tumor board in which many of the, not only the decision has to be taken by the tumor board, which is most important and more rational for that. And therefore, a very good multidisciplinary approach is necessary for that. And by this approach, now in the present scenario, the trend is towards improved survival. Nobody was thinking of survival in advanced disease in ovarian, but now with this advanced aggressive surgery, with the changing concepts of some of the platinum-based chemotherapeutic agents and newer chemotherapeutic agents, and the scientific analysis by the various team in this component of the tumor board, I think there is definitely a trend towards improved survival. Last but not the least, I must admit and reiterate again the situations that whose domain is ovarian cancer. Ovarian cancer domain, whether domain of a general gynecologist or a gynec oncologist. I feel that when it comes to the genital, out of all the genital malignancy, when ovarian comes and the surgery comes, remember the primary surgery is the best surgery. And it's not only the surgery, the decision, the staging is also equally important for that. And therefore, I feel that the domain of this ovarian malignancy is of gynec oncologist, not of general gynecologist. But at the same time, I told again, reiterate, that the general gynecologist should also have a basic understanding and fundamental knowledge regarding this ovarian cancer. And they are the first point of contact where they are the persons who have a right referral, whom to refer, where to refer, and when to refer. And this is important. A coordination between the general gynecologist and the gynec oncologist is absolutely mandatory for the survival for a longer term. Now today, in this particular episode of 27, these are the flow of events I will touch. Epidemiology and risk factors, types and classifications, pathogenesis, any preventive aspect, screening if at all it exists, or at least early diagnosis. What are the advances of tumor markers? What is the place? What is the role of imaging studies? And a new concept and a novel concept by the International Ovarian Tumor Analysis Group, and the classification is a very useful clinical application preoperatively to decide that what should be, whether it's a benign or a malignant, which I will touch. The diagnosis and the diagnostic pitfall, the staging of the disease and the changes in the staging of the disease, the FIGO staging, and last but not the least, our theme, the surgical options. And in the surgical options, right from the conservative to radical to ultra radical, what are the tips and tricks I will cover in this episode within a couple of hours. Now coming to the epidemiology and risk factors, it is second commonest gynecological cancer out of which 2 lakh new cases added every year in India. I've told about the global scenario, but Indian scenario is also quite high. And the Globacon 2020 has given an increased incidence of all types of genital malignancies during the past 2 years. There is a sharp rise in incidence in India. Highest disease-related mortality rate. Again, this is important. A woman has 5 to 7% lifetime risk on ovarian neoplasm and 1 to 2% lifetime risk of ovarian carcinoma. 15 to 20% of genital malignancies are ovarian carcinoma, and out of which 80% are epithelial in origin and 80% presence in advanced stage. That's the paradox. Germ cell tumor accounts for 20 to 25% of ovarian tumors, particularly in the adolescent. 3% malignant common in second and third decade of life, younger age group, and 5 to 10% are specialized malignancies or ovarian tumors, which are sex-called stromal tumor. Now, what are the risk factors? When we were students, absolutely nothing was being known excepting the fact that pregnancy and contraception are 2 preventive aspects for ovarian malignancy. And the main cause is attributable either genetic or the talc, which is being absorbed from the vulva through the genital tract to the ovary, and that could be a leading carcinogenic agent for that. But now it is well established regarding the age. There are various risk factors. I believe that few are known, many things are not known. Out of the known factors, age is very important. Ovarian malignancy, particularly the epithelial ovarian cancer, usually manifests in elderly age group. But there is an increasing trend, changing trends during the mid period also reproductive life. We see very often this incidence of epithelial ovarian cancer. Nulliparity is important factor, as I told, that pregnancy protects, and this is by virtue of a period of anovulation. When there is a repeated ovulation over the periods during the whole reproductive life, it is a risk factor for malignancy. And therefore, early menarche and late menopause, these are candidates more prone for the ovarian malignancy. Early menarche, late menopause with nulliparity aided the risk of ovarian malignancy. And the fathala, we remember the concept which I will tell little later. Of late, the therapy, iatrogenic causes, particularly relevance, is ovulation induction agents. The incidence of infertility with the current situation is now increasing, and they are conscious about it. The use of ovulation induction agents by the general gynecologist as well as the fertility specialist, not only from oral ovulogents, but injectable gonadotropins use, both for the normal ovulation and in anovulatory women, or in a case of assisted reproductive technology, where large doses of gonadotropins are being used. This has some adverse effects on ovary and genesis of the ovarian malignancy. The genetic and familial has been there since long, and more research is there to study the pedigree analysis and the various components of the genetics, relation of the genetics or the familial, impact on genesis of ovarian malignancy. We know very clearly, the clinicians, that if there is a strong family history of ovarian malignancy or a breast malignancy, I think these are more prone to develop ovarian malignancy in the particular spouse. And there are a lot of researchers, whether the maternal side, whether the sibling side, or the paternal side. The maternal side is more important in causing this familial incidence of malignancy. And 3 recorded aspect has been there related to the genetic and familial, which has been established. One is hereditary cancer syndromes, hereditary breast ovarian cancer, HBOC, and different the genes, and BRCA1 and BRCA2 has been proved to be associated, and the Lynch syndrome. The Lynch 2 syndrome, this is also linked and a risk factor for ovarian malignancy, which has been established, scientifically proved. Now, coming to the types of carcinoma ovary, particularly the epithelial tumors, we have divided histologically as far as the histopathology is concerned. Serous adenocarcinoma, mucinous adenocarcinoma, endometrioid adenocarcinoma, clear cell adenocarcinoma, malignant Brenner, mixed epithelial and mesenchymal adenocarcinoma and carcinosarcoma, squamous cell carcinoma, mixed carcinoma, undifferentiated carcinoma, and small cell carcinoma. These are some varieties of these tumors. The origin is different and the manifestations are different. The prognosis is also different in each type. WHO and FIGO combinedly gave a classification based on the histogenesis. In the histogenesis, they divide broadly categorized as two different entities, epithelial and non-epithelial. Because epithelial contributes to a significant proportion of malignancy, and epithelial, as I've already told, has been divided into serous, mucinous, endometrioid, clear cell, Brenner, benign, borderline and malignant, mixed epithelial, undifferentiated, mixed mesodermal, and unclassified group. And non-epithelial has become two parts. One is a germ cell tumor, another is a sex cord stromal tumor. In the germ cell tumor, the undifferentiated germ cells are the dysgerminoma, whereas the differentiated cells, germ cell tumor, are designated as non-dysgerminoma, in which it is divided into teratoma, immature, mature, and monodermal, or EST, embryonal carcinoma, and choriocarcinoma. So these are all differentiating into the different components. Therefore, these are non-dysgerminoma. Sex cord stromal tumors are granulosa cell tumor, granulosa theca cell tumor, fibroma, androblastoma, gynandroblastoma. The concept of this as regards the prognosis is also variable, because epithelial have really a worst prognosis, whereas the other epithelial as well as the adolescent, the non-dysgerminoma, absolutely prognosis-wise is worst, whereas the sex cord stromal tumor and dysgerminoma, the prognosis is little better, where we can think of fertility-sparing surgery and think of continuation of life with conservative surgery for that. Now, the newer concept of classification of epithelial carcinoma is very simplified as far as the clinician's perspective. They divide into high-grade serous carcinoma and low-grade serous carcinoma. High-grade accounts for about 70%, and low-grade serous carcinoma accounts for about less than 5%. Whereas the endometrioid carcinoma and clear cell carcinoma, mucinous carcinoma, and attributable for 10%, 10%, 3% each. So this is a very simplified classification as a clinician's perspective, and one should target and one should think, and more attention is to be given on this particularly high-grade serous cell carcinoma, the origin, manifestations, and the treatment modality. Now coming to the etiopathogenesis. From the beginning, I told that majority of the etiopathogenesis, the classical, is not known. But some factors is known, and out of these factors, one is very certain that there is a decreased risk in full-term pregnancy, twin pregnancy, OCP use, prolonged breastfeeding, tubal ligation, and hysterectomy. This clearly depicts that pregnancy is protective, contraceptive use is protective, hysterectomy is protective, because it has been statistically seen that more than 5 years use of OCP, there is a 30 to 50% reduction over in carcinoma, and it persists well after discontinuation also. So this is certainly an evidence-based and a scientific formulation for that. Way back in 1971, Muhammad Fatala, the past president of FIGO, gave a wonderful and revolutionary hypothesis that incessant ovulation is an aberrant DNA repair, and that is the initiation of epithelial ovarian carcinoma. And that is why the pregnancy, the contraceptive, and any drug causing anovulation or pregnancy, lactation, that is a protective effect for that. And therefore, frequent ovulation gives rise to frequent trauma in the ovary. And this mechanical trauma every month in the ovary is detrimental, and that starts the process of oncogenesis. Gonadotrophin hypothesis, as I've already told, the fertility promoting or inducing agents, ovulation inducing agents, and more commonly the gonadotrophins, LH and FSH, excess stimulation is a cause for ovarian malignancy. Now there is some change in that. The solace to the fertility specialist that this association of ovulation inducing agents is, number one, a dose related. Second, the histopathology is little different, that they manifest in the borderline tumors or low malignant potential, the prognosis of which is much better than the epithelial tumors. Estrogen and progesterone, nothing is being known, as we see that in endometrial carcinoma there is a definite relationship. The breast carcinoma there is a definite relationship. But in ovarian, there is a big question mark. Research is underway for that. Endometriosis. We know that endometriosis is a benign disease. Now there are many studies which reveals that the risk of ovarian cancer is elevated 4.2-fold with a long-standing endometriosis. And this is a clinical dilemma for the general gynecologist also. It is a question from the patient every endometriosis, and we convinced that this is not a malignant disease, this is a benign disease, but very painful disease. But it's not always so. Some women might develop malignant transformation out of endometriosis, and we have seen some cases where we do not know the cause and which woman will go for a malignancy and what are the factors giving rise to the malignant transformation is not yet known for that. And that's really a dilemma before the clinicians and the gynecologist. Now, as we focused more attention on epithelial ovarian cancer, which accounts for the predominant variety of ovarian malignancy, these two very important aspects I must give a message today. When 2016, Kurman et al. Proposed a very logistic and a very scientific and rational concept that the pathogenesis of epithelial ovarian cancer, there are two tumorigenic pathways, type 1 and type 2. And this is a very new concept where I want to dissipate the knowledge before all of you. And you understand that. It's very convincing. And it's important and relevance also as far as the treatment is concerned, as far as the presentations are concerned. Type 1. It develops from either extraovarian lesions that implant over the ovary and subsequently undergo malignant transformation, or from a portion of ovarian surface epithelium that entrapped within ovarian cortex, mutation into various types like mucinous, endometrioid, and low-grade serous carcinomas. And this is very clear. This type 1 gives rise to large unilateral cystic lesion without ascites. These are clinically and commonly indolent disease. These are diagnosed early and account for 10% of ovarian cancer deaths. This is a relief. Type 1 is really solace to the gynecologist. Whereas type 2 is a high-grade serous carcinomas arising from distal fallopian tube and fimbria. I think that concept has been proved by various authors since last 10 years. And the postulation of what is called a stick, the serous tubal intraepithelial carcinoma, the stick and progression to the invasive cancer. So now we believe that the majority of the high-grade squamous cell carcinoma is not originating from the ovary. It is from the tube. And therefore, stick is a condition where it is a serous tubal intraepithelial carcinoma. And researchers have proved that it is a precursor condition for invasive and develops several years before initiation of carcinoma ovary, but metastasis follow rapidly thereafter. And this accounts for 90% of ovarian cancer deaths in contrast to type 1, which causes 10% of the cancer deaths. Now, thought comes to everybody's mind now, and also I will impress on the fact that if at all we know, this is the only aspect we know, the course of the disease, a long journey and a precursor condition. It develops several years before initiation of invasive cancer. So if at all we want to have a prevention, if at all we want to have an early diagnosis, I think that is very important. Can we diagnose it during the phase of stick? That's the point of research now. If we can find out and diagnose and catch the patients when at the level of the stick before initiation of carcinoma ovary, we can do a great job in this dreaded disease of not only prevention but early diagnosis. So research is aimed at diagnosing stick very early, and till date we are not very clear about it. So therefore, to sum up, this has been approved, the dualistic model of ovarian cancer genesis. The dualistic model type 1 and type 2. The type 1 endometrioid, low-grade serous, mucinous, transitional mucinous, and Brenner. These are all type 1. And histogenesis, pathogenesis, I've already clarified that. Whereas type 2 is from the fallopian tube and distal fallopian tube and the fimbrial end, which becomes high-grade serous. And this is very, very important. And that can give rise to other histological subtype like transitional type, carcinosarcoma, and undifferentiated sarcoma. And therefore, the prognosis of type 2 is really worse, much worse than the type 1. So this is a very new concept which everybody should understand, the dualistic model of ovarian cancer genesis. And therefore, if we get a type 1, we're a little happy. Type 2 really is a mortality, is a great question mark for that. This is a thing which I say that the normal epithelium with the stick, the histogenesis or the pathogenesis, P53 signature is there. When it touches the ovarian surface epithelium, the fimbrial end touches the ovarian epithelium because of the anatomical proximity, the beginning of carcinogenesis starts there. And this stick is definitely a precursor of the invasive carcinoma. Now, a little bit about this borderline tumors or low malignant potential. This is again a histological diagnosis, and the histological and biological features which is intermediate between benign and frank invasive carcinoma. And it presents at any age. Association with ovulation inducing agents, I have already clarified this. Histological difference makes it very clear about LMP, low malignant potential. And at least two of the following features, if it is there, we can say that it's a borderline tumors. One is a nuclear atypia, epithelial stratification, microscopic papillary projection, cellular pleomorphism, mitotic activity. Any two, if it is there, then we can say that it's a borderline tumors. And it has a better prognosis, and this particular entity has a role in fertility sparing surgery. Definitely a conservative surgery can be warranted in this particular case. Now coming to the prevention, again highlighting about when we do not know certain risk factors, some of the risk factors which we know, we target for that. First is a chemo prevention. The chemo prevention is by COC. There is a myth that COC is many side effects. But the merit, one should understand that this is the only definite merit, that the dose related, the years you use with COC, and even after is protective of ovarian malignancy and particularly epithelial ovarian malignancy. So chemo prevention and surgical prevention. Surgical prevention, there are two aspects. One is a prophylactic bilateral salpingo-oophorectomy. We cannot do in all cases because ovary has a much more wider role to play. Even the family is completed. Universal, we cannot do it, but at least there's a high risk category where there is a risk, we can do a prophylactic bilateral salpingo-oophorectomy. And this has been practiced also. Now, literate women, they very much know that a strong family history of ovarian malignancy or a breast malignancy or a known breast malignancy or a BRCA1 positive or a BRCA2 positive, after the family is completed, even normal ovaries, you do a prophylactic bilateral salpingo-oophorectomy that is going to prevent 100% of the cases. Third important concept, when we know that the high-grade serous carcinoma of the ovary is not of ovarian origin. It is from the distal end of the tube or the fimbria. And therefore, now it has become recommended practice for all surgeons doing a benign disease, doing a hysterectomy for benign disease. They will keep the ovary for the ovarian, for the hormonal pattern, but at least remove those tubes. Opportunistic salpingectomy for all during all benign conditions needing hysterectomy. You may keep the ovaries, but at least remove the tube. And that has become a part of the practice and a mandatory practice for all surgical, all gynecological surgeons. And that concept has given rise to it. Gone are the days where we were thinking that if we remove the tube, ovarian blood supply is being compromised. And therefore, even in hydrosalpinx also, keep the tube. And we were keeping it. Now, after this concept, a dreaded disease can be prevented if you do a salpingectomy for that. And ovarian vasculature is not being compromised fully if you remove the ovary. And therefore, it has become practice universally by all benign gynecologists, including me. Now, coming to the screening aspect, which is a very great enigma. The screening, we know the course of the disease, we do not know the long journey and the initiation of the course, excepting some of the high-risk population. The high-risk women having a BRCA1 or a BRCA2 carriers, strong family history of breast and ovarian carcinoma, Lynch syndrome, and these are the cases there is a need for screening. So instead of a universal screening, I think at-risk women must be subjected to screening, whatever is available at our hand, the screening options. And need for genetic screening is also essential. The pedigree analysis is also essential. The recognition of the BRCA1 and 2 is also required if there is a family history. Now, this, after knowing that these are at-risk women needing screening, important. What are the options of screening at our hand? There are limited options in our hand. And the modalities of screening is also variable. One is a clinical examination, vaginal examination, which is very often a time of guesswork. And more so when the sonographic has become a part and parcel of gynecologist. CA125 evaluation, serial evaluation of CA125. There is absolutely a close agreement with the epithelial ovarian cancer, although we know that CA125 level, the single level, may vary starting from malignant to non-malignant conditions also. And there is a differential reference value for premenopausal and postmenopausal. And there is a significance, but still it has some basis related to epithelial ovarian malignancy, and more so a serial evaluation, not only for diagnostic purpose, but prognostically it's very important. We know that these tumor markers are very important for prognosis and therapy, but for diagnostic also, for screening also, it is also equally important for that. but not in one, but combination of all these can have a better effect. Then the man and machine now has improvised. The real-time ultrasound machine, having a good resolution and more so by transvaginal ultrasound, can depict clearly about the pelvic organs and more so about the ovary with or without the colored Doppler. And this is important either alone or more in combination and help the screening, particularly in the at-risk population for that. And however, it is not the effective screening. It is not the universal screening, which I mean that it's useful for that. But even that, we need that early diagnosis is the need of the hour than the screening. With this least effective role of screening, we emphasize on the early diagnosis. And till we wait for a new novel concept and research, when effective screening options are available, we'll be happy with this particular entity at present. So ovarian cancer has thrown great challenges as regards screening and early detection. There is no preclinical and pre-malignant phase of the disease in contrast to cervical cancer, though the hypothesis of stick to the invasive takes long years and it is still under awaiting research. Carcinogenesis is a multifocal and polyclonal in origin. It has no known etiology. 90% are sporadic in onset as compared to a meager 10% that are part of hereditary ovarian cancer syndrome. With this background, screening for ovarian cancer would imply early diagnosis of stage 1 disease, which is usually asymptomatic and carries a high survival rate with particular attention to screen the high-risk subject. Now, what are the screening modalities? 3 screening modalities: bimanual pelvic examination, imaging technology, and the tumor markers. Bimanual pelvic examination had a specificity of 97.3% and ovarian cancer, but a specificity of 99.6% is required to achieve a positive predictive value of 10% in postmenopausal women. So, to summarize or to conclude, bimanual examination is not very, very significant as one component of screening. Although we cannot ignore the technology has developed, but the touch we cannot ignore. The blend of tech and touch is important and form a basis on screening, diagnosis, and therapy. Second important, we have developed more on the ultrasound, TVS, colored Doppler, CT, MRI. The imaging plays a great role in this early diagnosis for that. And therefore, the colored Doppler, the concept of neovascularization or angioneogenesis in malignancy is the preliminary step. From that concept, the colored Doppler is of profound value in the diagnosis of ovarian malignancy. And tumor markers, out of which various tumor markers are there. CA-125 tumor marker, a serum glycoprotein antigen, elevated in 80% of the case of epithelial ovarian cancer, and is elevated in 50% of stage 1 and 90% as per the stage is concerned, the level rises considerably. But it also is raised in benign conditions like endometriosis and other conditions also. So the multimodal screening approach should be done, not by only one method one can reach at a conclusion, but the multimodal screening approach is mandatory. Now coming to the tumor markers, the WHO initiative. The serum CA-125, again, the level varies as regards age, as regards the premenopausal and postmenopausal status. In the postmenopausal is very, very significant. Prognostic value is very significant, CA-125. And in a premenopausal, less than 40 years, the other things has to be considered along with the serum CA-125. The CEA, which is high in mucinous variety, the serum alpha-fetoprotein, serum beta-HCG, and serum LDH, which are really important for the adolescent, particularly for the germ cell tumor. This definitely has a linkage between that. And apart from it, OVA1 and HE24, these are 2 additional tumor markers which is under great research, which can contribute to the significant to the diagnosis as well as prognosis of ovarian malignancy. CA125 is of primary importance in epithelial carcinoma. It's a high molecular glycoprotein, elevated in 50% of stage 1 and 90% of stage 2 ovarian cancer, elevated in 80% of non-mucinous ovarian cancer, 30% of non-ovarian malignancies, and 6% of benign diseases, and in 1% normal women also. So these are all big. Rising level has more predicting value than the static level. This is so important. A serial rising value is more important than a single absolute value for that. So risk of ovarian cancer and risk of ovarian malignancy, ROCA and ROMA, these have been a lot of scores which have been there, and these scores one can identify the specificity and sensitivity and a positive predictive value. ROCA, age, rate of change of CA125 and absolute level, and ROMA, HE4 tumor marker, CA125 and menopausal status. Now coming to the imaging in ovarian cancer. What are the implications of imaging and what are the imaging technology we utilize for that? Abdominopelvic scan routinely, and more when we come to the pelvis, the transvaginal sonography of immense value. Added to it is a collar Doppler. We know the vascularity or angiogenesis. That will signify unilateral or bilateral masses, multiloculated, solid cystic complex, size, nodularity, papillary projections, neovascularization, and ascites. These are few sonographic pointers which can give an idea about benign or malignant. And basing on that, the IOTA definition, the International Ovarian Tumor Analysis Group has been very categorically described it and differentiating from benign to malignant, because this is important preoperatively to decide whether it could be malignant and whether it could be the benign, and more so in a younger individual when the decision matters, and therefore we need help of this. Another is a CT scan and MRI. MRI will characterize the mass and extension inside the pelvis, but CT scan is more useful for upper abdominal mapping, the omentum, and upper abdominal disease. CT can give more light, including the nodal status for that. Regarding the bone scan and PET scan, I think these are the cases where it's a high-tech, it's more academic interest for that. And for follow-up, this is important, PET scan and bone scan, not for a primary diagnosis for that. So again, you have to decide before end surgery in ovarian malignancy that there are some many clinical dilemmas and surgical dilemmas. And what are those? There could be some ovarian versus non-ovarian. We do a neck cell lump. How could you know that is ovarian or non-ovarian? That one must distinguish. Whether it's a functional or organic, whether it's a symptomatic or asymptomatic, unilateral or bilateral, benign or malignant, that's the point of concern today. Elective or emergency, whether laparoscopic approach can be better or laparotomy approach can be better, and whether the decision is for organ preservation, conservative versus radical surgery. And therefore, this International Ovarian Tumor Analysis Group is very, very important and very convincing and very convincing and rational. The classification system, the scoring, and it helps in decision making. This is very important. It will give an idea about to the gynecologist that whether you go for a surgery and what type of surgery you should devote for that. Now, broad perspective and understanding of the aorta signifies the ovarian cyst and tumors. And the range starts from understanding the normal ovary, to the understanding of the functional cyst, to benign tumor, borderline tumor, to invasive tumor. How the aorta classification can help us in distinguishing this. The concept of this IOTA International Ovarian Tumor Analysis Group divides the premenopausal and postmenopausal. And this is the prevalent, this is the classification or the components or the grades of level starting from normal ovaries to benign ovarian tumors to borderline ovarian tumors to invasive ovarian carcinoma. In premenopausal, we find that the invasive ovarian malignancy is accounting for a smaller proportion, whereas in postmenopausal women, the invasive ovarian cancer is occupying a larger proportion and gradually decreasing borderline, benign ovarian tumors, and of course the normal ovaries. So the classification system for adnexal mass, which I again repeat: benign ovarian, benign non-ovarian, primary malignant ovarian, secondary malignant ovarian. Again, I am in this episode, I'm again reiterating the concept of International Ovarian Tumor Analysis Group. I've already described in case of ovarian tumor episode. Now, benign ovarian, polycystic ovaries, functional cyst, endometrioma, serous cystadenoma, mucinous cystadenoma, mature teratoma, fibroma, and thecoma. Whereas benign non-ovarian, paratubal cyst, hydrosalpinx, tube ovarian abscess, peritoneal pseudocyst, appendicital abscess, and pelvic kidney. And primary malignant ovarian, epithelial carcinoma, in which the borderline, serous cystadenocarcinoma, mucinous cystadenocarcinoma, endometrioid carcinoma, clear cell carcinoma, germ cell tumor, malignant teratoma, dysgerminoma, sex cord tumor, granulosa cell tumor. Secondary malignant ovarian, 10% of the ovarian malignancy, and predominantly originates from the breast or gastrointestinal carcinoma, and it is classically described as a Krukenberg tumor since long. So the IOTA definitions focuses attention on whether it is a unilocular solid, multilocular or multilocular solid or cystic. Cyst contains whether anechoic, low level echo, ground glass appearance, hemorrhagic or mixed, solid material or papillary structures or wall irregularity, its presence, and what are the number and the size. And this is very important, color Doppler, vascularity. Shadows are also important. And along with that, what is the condition of the peritoneal fluid as a presence of ascites. So the simple description, certain abnormalities are really obvious. And the pattern recognition is important. And any general gynecologist doing an ultrasound can diagnose that. Endometrioma, benign cystic teratoma, simple cyst or cystadenoma, functional cyst or hemorrhagic cyst, malignant tumor with ascites. These differential diagnoses one must think about these other possibilities and what are the sonographic pointers which can differentiate one from the other. So there are simple rules. The features of a benign mass are known as a B features. B features are from B1 to B5. So what are the B1 features? Unilocular cyst is B1. Presence of solid components with the largest diameter less than 7 millimeter is B2. Presence of acoustic shadows is B3 as we see here. And smooth multilocular tumor largest diameter is less than 100 millimeter. And B5, no blood flow. Color score is 0 or 1. These attribute to B features. And a mass is classified as benign if at least one B feature is present and no M features are present. So there are two categories you must identify, sonographic pointers, B features and M features. And a mass is classified as benign if at least one B feature is present and no M features are present. And features of malignant mass: M1, irregular solid tumor; M2, presence of ascites; M3, at least 4 papillary projections; M4, irregular multilocular solid cyst with largest diameter more than 100; M5, very strong blood flow or vascular mass. So therefore, a mass is classified as malignant if at least one M feature is present and no B features are present. So the conclusion is that the B and M features are the sonographic pointers. When one M feature is there and no B features are there, it is classified as malignant. And one B feature is there and no M feature is there, then it's classified as benign. Now the problem comes, what is in the middle? So if one or more M features are present in the absence of B features, the mass is classified as malignant. If one or more B features are present in absence of M features, the mass is classified as benign. This is very clear. But rule 3, if both M features and B features are present, or if no B or M features are present, then the result is inconclusive. And here a second stage test is recommended. And therefore, you can eliminate this particular group that these are inconclusive. But the conclusive, at least we can find out clearly out of all these groups, so that you can be very target therapy, considering that this is benign, this is malignant. And where an inconclusive test is there, you have to corroborate with the other findings. And may be that with that inconclusive finding, you take a decision for a per-operative histopathology. Diagnostic modalities. Again, clinical. And clinical is more accurate in advanced disease, but in early disease, it's a very important, I think, $1 million question. Imaging, I've already told about the sonography, color Doppler, and iota classification. This is very useful classification. And of course, the tumor markers. Now coming to the symptomatology, as far as the diagnostic bit. These are all vague symptoms. Ovarian manifests with the vague symptoms. Increased abdominal size, bloating, dyspepsia, pelvic pain, fatigue, constipation, backache. These are all vague symptoms which is there. Women and clinicians often attribute most symptoms to menopause, aging, dietary changes, stress, depression, or functional entity, and therefore delayed diagnosis. This is not a concern of the women. It is a concern of the clinicians, and also think like that. And when they come with the presentation as a perception of lump, or on pelvic examination, they find an adnexal lump, or a nodularity in the pouch of Douglas, or a fixity of the mass, or presence of ascites. That is obvious at that stage. But by that stage, the disease has advanced for inoperable. Now, a little bit about parasynthesis. Few years before, this was an armamentarium, and more so before the era of sonography, both for diagnostic as well as therapeutic. The diagnostic purpose is that you do a parasynthesis, send a peritoneal fluid for cytology and evidence of malignancy. And this is very, very important when in early days, we want to differentiate from tuberculosis. So tuberculosis and malignancy, when we are different, there is no gadgets available. Tap it and send it. And therapeutic for relief of the symptoms. And this relief of the symptoms is mainly when the ascites is much more, and therefore this is important. So therapeutic. And when sonography came, it has a more sonographic guided aspiration, which is really localized where the fluid is there, instead of guessing and finding out. Now, I remember there was an era where FNSE was used as a gadget. And then after that, we see the consequences. And therefore, we say that FNSE is a criminal diagnostic gadget. So when we suspect ovarian malignancy, at least parasynthesis is relatively safer, but don't do FNSE in that. Until today also, Alfie, that there is no role of FNSE, because we know, to be very clear, when we go for the staging, when we know that the spillage is an entity for that, you are encouraging it and promoting to a more advanced disease rather than limiting to a early disease for that. So FNSE, say controversy is over, don't do an FNSE from the tissues. Now coming to the staging of ovarian carcinoma, FIGO staging have been revised from 1988 to 2014. And the staging of ovarian cancer FIGO 1988 into 1, 2, 3, 4. And again, divide whether it's a one is limited to ovaries, one ovary or both ovaries, or with the capsule rupture or a tumor on the surface or positive peritoneal washings, on 2, 1 or both ovaries with pelvic extension, and one or both ovaries with microscopically confirmed peritoneal metastasis outside the pelvis or positive regional lymph nodes as stage 3, and again ABC and distant metastasis on stage 4. There's an additional in 2014 were more focused and descriptive about revised staging, and where they have given importance to the TNM and eliminated some of these entities. This is a comparison between the stage 1 limited to ovaries between the 1988 and then the 2014. 1A, 1A and all that. But 1C, tumor limited to one or both ovaries or fallopian tubes with any of the following: surgical spill, capsule ruptured, or malignant cells in the peritoneal cavity for that. Now, earlier the 2C, now in the 2014, 2C has been eliminated for that. So tumor involves one or both ovaries is known as pelvic extension with pelvic extension. Whereas when the concept of ovary, tube and peritoneum is same as the same spectrum, in the 2014, the combination of fallopian tubes also and ovary has been incorporated as one entity for that. And therefore, instead of ovary, the fallopian tubes also has been included in that. And the pelvic node and the parotid node metastasis and the size of the node is also taken into account in the 2014 rather than the 1988. And stage 4, also the parenchymal metastasis in stage 4B in the liver, particularly in the liver, has been incorporated for that in extra-abdominal organs. Now coming to the management. The broad outline of management deals primarily the surgery. Surgery is the mainstay of treatment for ovarian malignancy. And there is some additional treatment in ovarian malignancy. It's not the solo treatment, the neoadjuvant chemotherapy. The concept of neoadjuvant chemotherapy came when a disease is advanced stage, and in more advanced disease, primarily diagnosed by the different gadgets. Prior to surgery, we give the drugs. Neoadjuvant chemotherapy has to be given for 3 courses to limit the disease, to have limitations of the disease and confined to a smaller entity, and then do a surgery for that. This is called neoadjuvant chemotherapy, NACT. And then after that, you can give another 3 courses of chemotherapy for that. This has certain benefit of it as far as the survival is concerned. Earlier, we were doing a primary surgery in all cases because the tissue diagnosis is important for that. But now with the improved gadgets available, we diagnose in, particularly in more advanced disease where it is confirmed. This has become very useful and a popular thing. And of course, there is no doubt that adjuvant chemotherapy plays a great role in ovarian malignancy. And adjuvant radiotherapy also has some benefit of it. Now, I will focus attention to the surgery, not for the chemotherapy part, because our main attention is a surgical options for that. Now, therefore, whether to do this surgery or not, that's important. Decision for surgery, that is important. And therefore, preoperative non-surgical staging. We know that ovarian surgery, surgical staging is mandatory. And before surgery also, when we are contemplating the neoadjuvant chemotherapy, I think this pre-op non-surgical staging has definitely got some merit of it. And meticulous analysis of clinical presentation and imaging studies with the relationship or the linkage between the two, we can reach at a conclusion for that. And of course, these are the cases where it needs a multidisciplinary approach or a team. As I've already told, the combination, the multidisciplinary team of the gynec oncologist, the surgical oncologist, the radiotherapist, the chemotherapist, all should have a tumor board and decide regarding the surgery and what type of surgery is there. And if you're going for a surgery, this decision is very important. When you go for surgery, that's number one. Where surgery has to be performed, I think this is again an important part in a very referral center. And who to operate. I've already clarified that here in ovarian malignancy, who means domain of the gynec oncologist. with or without the help of the surgical oncologist, whichever is concerned. But primary surgery is the best surgery. Both the decision and dissection will be much better if a gynec oncologist handle those cases for that. And pre-op assessment. These are some of the criteria for pre-op assessment. When we were students, on in our early days, mainly there are some clinical criteria of differentiation from benign to malignant. What are those? Age of the patient, younger, germ cell tumor, older, epithelial ovarian cancer. Then second is the rapidity of the growth, clinical, mainly based on the clinical. Bilateral, if the bilateral is there, more malignant. Tumor fixity is there, it is supposed to be malignant. If the ascites is there, it is supposed to be malignant. These are clinical assessment criteria. Now, the gadgets has helped us into another 3 more important imaging science complex, imaging science like ultrasonography, and more so with added color Doppler, a complex mass, and with the definite sonographic pointers, which I've already elaborated, the CT and MRI finding a metastatic nodule, and of course, in association and correlating with the elevated tumor markers. These are some 3 new additional armamentarium at our hand, in addition to our clinical sense. The preoperative assessment, there are various scoring system which is there, and risk, and Jacob was the first person to devise and gave a concept way back in 1990, the RMI, risk of malignant index scoring. And Jacob scoring, risk of malignant index RMI is U into M into serum CA125. And the cutoff limit is 200, less than 200 and more than 200. There are some criteria in ultrasound, assessment criteria in ultrasound, and given a score: multiloculated cyst, evidence of solid areas, evidence of metastasis, presence of ascites, and bilateral lesion. These are sonographic pointers. And what is the score? Score 0 when none of the above are present. Score 1 when 1 only is present. And 3 when 2 or more are present. Then it is RMI USG. That score you put it multiplied by the menopausal status. If it is a pre-menopausal, it is 1. If it is a post-menopausal, it is a 3. And multiply by absolute value of CA125. That gives a account for whether it's a 200 or less. So an RMI of 200 had a sensitivity of 85% and a specificity of 97% for diagnosing ovarian cancer. So the Jacob 1990 gave a revolutionary concept and some quantitative measure, and to define that it's a malignant and non-malignant, and from which different algorithms have been devised as far as the treatment modality is concerned. Now, surgical options. If we decide for surgery, what are the different types of surgical options at our hand? The type of surgery, whether it's a conservative surgery or fertility sparing surgery, or a radical surgery, or an ultra radical surgery, in more advanced. Then the 2 main points of debate is again the second is a laparoscopy versus laparotomy. In the present status, place of laparoscopy in gynec malignancy, cervical. After the LSCC trial, it has been clearly depicted that at present, CA cervix laparoscopy is inferior to the laparotomy. Of course, endometrial laparoscopy can be used at par or even superior to the laparotomy. But as regards the ovarian is concerned, laparoscopy, where there is a place, it is a skill-dependent surgical maneuver, and with the expert, with the surgical oncologist or a gynecological oncologist skilled in endoscopic procedure, they can venture for the laparoscopy, and the results can be at par with the persons doing a laparotomy. And in laparoscopic procedure, the main thing about hysterectomy and bilateral salpingic oophorectomy is a simple job. But in complicated cases, when there is a more of adhesions and involvement of the other pelvic structures and more so the lymph node lymphadenectomy, particularly the para-aortic. The skilled surgeon can do endoscopic procedure. And second important is the retrieval, tissue retrieval. And tissue retrieval by endo bag or endo catch bag has become practiced for that. But still, the place of laparoscopy is restricted to skilled endoscopic surgeon for that. And maybe that in future, more advances could be there in this regard for that. One is a dissection. Retroperitoneal dissection has become very improvised and endoscopic method. And then the retrieval. And of course, the nodal status, mainly the para-aortic nodal status. And the omentectomy, I think this is a skill, this depends on the skill of the surgeon for that. But whatever it may be, primary surgery is the best surgery for that. Don't compromise the primary surgery. It will absolutely be directly proportional to the prognosis of the disease and the survival. Interval debulking surgery, again, IDS is one of the concepts that interval debulking surgery you do it, and in between you debulk the surgery after chemotherapy or suboptimal surgery. If you have done a suboptimal surgery or after chemotherapy like NACT, you do an interval debulking surgery. Surgery for recurrent disease like a secondary cytoreduction, palliative surgery, fertility sparing surgery, surgery for elderly patients, surgery during pregnancy, and surgical options for borderline ovarian tumors. These are very, very special situations where the surgical options vary. As for example, borderline ovarian tumors, we know there's a low malignant potential. Even we can do it, and it can be tackled both by the laparoscopy as well as for a fertility sparing surgery. These are the two main aims for that. Stage 1A1, these are the early stage disease, can be tackled by laparoscopy or by the laparotomy, and the laparoscopy can have an equal, is a non-inferior to the laparotomy for that. As regards the staging is concerned, laparoscopy or laparotomy, laparoscopy can give equal or better surgical staging than the laparotomy for that. And therefore, as far as the staging is concerned, there is no difference. As far as the ultimate removal is concerned, there is a difference. So primary surgery, a meticulous surgical staging is important. And what are the principles of surgery? See, surgical meticulous, you open up, or by laparoscopy you do search from pelvic floor to diaphragm. This is the extent of searching. Both inspection as well as palpation. You palpate, you can find out a secondary primary lesion in the stomach, or palpate the node, nodal status can be palpated. And therefore, not only inspection, the palpation. Peritoneal cytology and wash is a must in all cases. And of course, imprint smear and Fogen section biopsy is a very invaluable component for the surgery. And when we go for the principles of surgery after surgical staging, the primary objective of ours is to have a surgical resection of a primary tumor with optimal cytoreduction of metastatic disease. That should be the principle, because we know that the prognosis always relates to the residual disease. How much is left behind, the dimensions? Either they are not, if the residual disease is more, the chemotherapy, post-op chemotherapy is not sufficient enough to act. And therefore, it has been proved beyond doubt that the survival rate depends on the existing residual tumor tissue. So the surgical procedures, the early stage, particularly the epithelial cancer, stage 1A, fertility sparing surgery with surgical staging can be done. If she wishes a pregnancy of is very young, but in menopausal or perimenopausal or premenopausal who have completed family, I think these classical total abdominal hysterectomy with bilateral salpingo-oophorectomy, with lymphadenectomy, both pelvic as well as para-aortic, and omentectomy, with or without appendicectomy. This is the component which has to be given for that. And here as regards the lymphadenectomy, if you compare the ovarian with the other genital malignancy, the para-aortic is more important. And it's not the pelvic lymphadenectomy which alone relieves the need for para-aortic sampling or node removal, gives a more better survival than only pelvic lymphadenectomy. 1B, 1C to 2A, again to total abdominal hysterectomy, bilateral salpingectomy, lymphadenectomy, omentectomy, appendicectomy with complete surgical staging. Always surgical staging is important. And here the skill or the technique of surgery could be a need for retrograde retroperitoneal approach. This in many cases helps because retrograde retroperitoneal approach is a method where you can completely dissect the mass right from the lateral in the peritoneum to the lateral pelvic wall to the central part and reflecting the pouch of Douglas peritoneum and the rectosigmoid superficial part. The involvement will be much better known how far it is involved rectosigmoid further. Although we know the extension by MRI. In advanced stage, the classical dictum is radical oophorectomy. And the philosophy is optimal cytoreduction or total tumor clearance and neoadjuvant chemotherapy. So for primary surgery, for limited disease early stage, surgical staging and conservative surgery in 1 and 2. For advanced disease, cytoreductive or tumor reductive surgery or TRS is important. Interval cytoreductive surgery is only indicated in suboptimal stage CT followed by surgery or restaging or NSCT followed by surgery. Secondary surgery, either it could be second look laparotomy or a secondary tumor reduction surgery or a palliative surgery for that. The goal of primary surgery is confirmation of diagnosis, surgical staging, extent of disease, evaluation, adjuvant therapy and prognosis is judged, optimum tumor reduction surgery for advanced disease, optimization of tumor status for cure by chemotherapy, and residual lesion should be minimized as far as possible. Radical oophorectomy is a concept where removal of all pelvic tumor is termed as radical oophorectomy. All pelvic tumor, not only the genital but extragenital. Retroperitoneal approach to remove the extension of ovarian cancer and the internal genitalia. And primary surgery in early stage disease, staging laparotomy, how you do it, always incision, vertical midline. No place for transverse incision. I always argue with our oncologist friend. Some endoscopic surgeon with a keyhole surgeon, they cannot tolerate giving an incision right from the top to bottom, but it is necessary. If you want a survival, it is necessary because you have to approach the upper abdomen or the para-aortic is a mandatory thing. For that, we need a midline, longitudinal, extended supra-umbilically. Evaluation of ascites or multiple wash cytology. By 300 ml normal saline, you wash it and then send it for cytology. Complete abdominal inspection and palpation. Again, I reiterate. Excision and biopsy of suspicious areas and lesions. Multiple intraperitoneal biopsy when no lesion is seen. And hysterectomy with bilateral salpingo-oophorectomy, infracolic or total omentectomy, lymphadenectomy and appendicectomy, more so in a mucinous variety. And 20 to 30% of early disease do have positive lymph nodes and para-aortic, and therefore para-aortic has become universal, particularly in ovarian. Exception is there when fertility preservation is considered in very early disease. Primary surgery conservative, some criteria to be fulfilled for conservative surgery. Fertility preservation is the goal. You should have a consent and a counseling for treatment with strict follow-up. No evidence of these genetic gonads and specific situations, any unilateral germ cell tumor, any unilateral sex cord stromal tumor, any unilateral borderline tumor, stage 1A invasive epithelial carcinoma. This is only limited criteria for conservative surgery. This is one example when one ovary has been removed for that. Again, as an advanced disease where you see the surface of the ovary which is not looking like a stage 1A1. So the conservative procedure, if you're going for a conservative procedure, meticulous surgical staging as usual, negative peritoneal washing or negative omental biopsy, unilateral salpingo-oophorectomy on affected site. Unaffected ovary may be spared from biopsy because earlier there was a recommendation that you do a biopsy to evaluate whether there is a spread to the other ovaries. But again, when we are going for a fertility promoting surgery, don't touch the ovary, the healthy ovary for that. It leads to unnecessary adhesions, ovarian failure, and mechanical infertility. Biopsy may be done if suspicious, covered with interseed to avoid adhesion further. If there is a suspicious looking, then you remove. So ovary conjoint should be removed after childbearing in epithelial ovarian cancer. If you are going for fertility sparing procedure, you counsel and you beforehand that you do the surgery, fertility promoting surgery, and then after that, you need to have the complete, again, re-surgery to remove that. So cytoreductive for advanced disease and a tumor reductive surgery for advanced disease. So complete when the residual is 0, optimal when the residual is 0.5 centimeter, suboptimal when the residual is more than 0.5 centimeter. I think this target for at least optimal or residual, less than 0.05, 0.5. The benefits are improvement of tumor response to further therapy by improving tumor perfusion, decreasing necrotic tissue. The efficacy of the chemotherapy is much more when the residual tumor is less. Removal of large tumor in omental cake reduces ascites, and that is a symptomatic control, symptomatic relief. Prevents bowel obstruction and improves nutritional status. Enhances immunological competence of patients, improves responsiveness to chemotherapy, and psychologically relief of removal of tumor bulk. She feels assured that all my cancer tissues have been removed. The advanced disease, the primary procedure again, midline vertical incision maybe up to Giffey sternum, exploration of abdomen, all primary tumors and metastatic disease and removal to a minimum residual of less than 0.5 centimeter. And of course, if there is a need, radical oophorectomy, retroperitoneal approach with retrograde hysterectomy to remove pelvic extension of ovarian cancer and internal genitalia. So, in the components of the primary surgery, apart from the staging, total omentectomy, appendicectomy, resection of rectosigmoid, small intestine, splenectomy as and when needed, peritoneal stripping when extensive peritoneal implants is there, diaphragm stripping when there is a deposits, resection of liver nodule, resection of retroperitoneal lymph nodes, both pelvic and aortic up to renal vein. Now, it's all right, but we have to weigh which are the candidates in advanced disease. This is an extensive surgery. The candidate selection, the fitness for anesthesia, and subsequently how far, how much we gain and how much you lose. That balance of judgment should be there in advanced disease if you're contemplating for an extensive surgery for that. And what do you mean by optimal surgery? Optimal surgery is complete when no residue is there. Again, macroscopic removal of microscopic disease. This is a big question mark. Optimal when the residue, macroscopic residue is less than 0.5 centimeter. This is all macroscopic. Suboptimal residue is more than 0.5 centimeter. So try to do an optimal surgery, leaving residue less than 0.5 centimeter at any cost, at any level, maybe in the pelvis or in the peritoneum or in the abdomen. Now, palliative surgery. Is it necessary? Palliative surgery for bowel obstruction, resection of obstructed portion, HTML, peaceful death she should have. Colostomy, chest tube for pleural effusion, drainage of huge ascites, and the purpose of the palliative surgery to add life to days, quality of life. Again, American Cancer Society has categorically correlated the stage with the survival, 5-year survival. Stage 1 and 2, about 95 to 65%. Stage 3 and 4, 15 to 30% in stage 3, 0 to 20% in stage 4. And overall survival is 50%. Now, of course, 20 years have elapsed. The newer technology has grown up. The overall survival has grown from improved from 50% to 65 to 70% now. And this is because of the newer generation of the chemotherapeutic drugs. This is because of the skill of the surgeons. And this is because of the critical care facilities available for monitoring and anesthesia facilities, including the intensive care. Now, before my surgical videos and a surgical skill transfer, the middle part I've kept it. The first part is over, a theoretical. I've given some form of knowledge before all of you. The second important part is a clinico-surgical dilemmas which I have faced. I must ventilate this to you people. You must have faced even those type or different types and then analyze where you stand. Situation 1. Very close patient of mine, Mrs. X, 42 years, para 2. And I was her obstetrician, both the deliveries of her child, I have done it. She presented, this is very unfortunate, I still remember the face of this patient. Presenting with dyspepsia, abdominal discomfort, backache, urinary frequency and dysuria. Clinically, I didn't find anything. Sonography, abdomen, pelvis is normal. Normal upper GI endoscopy. Consulted the gastroenterologist also, consulted the physician. UTI was found urine culture, treated with antibiotics. She has a temporary relief for a few days. Treated with anxiolytic, laxative, and other empirical drugs. She again presented after 15 days. Again, anxiolytic, laxative, and other empirical drugs. But I was thinking that she is relieved. But it presented after 2 months only with aggravation of symptoms. What is my finding? On examination, after 2 months, I find marked ascites, POD nodule, pelvic mass, increased CA125, and vascular ill-defined pelvic mass with omental cake on sonography. CT MRI, extensive pelvic and abdominal lesions, planned for neoadjuvant therapy and interval debulking surgery. Laparotomy was done. There was an extensive abdominal pelvic disease, almost inoperable. But subsequently, with the help of the surgical oncologist and my friend gynecological oncologist, some sort of suboptimal, I cannot say that it is optimal surgery, but at least we could do this surgery. And the biopsy comes as high-grade papillary serous carcinoma. And then she was supposed to go for a post-operative chemotherapy. But unfortunately, she died 20 days after surgery. I cannot forget this patient. And 2 children, 2 daughters of her, 1 son and 1 daughter, I have delivered those. And the message, presumed vague symptoms could be alarming in future. Rapid progress in aggressive disease and therapy is inconclusive. And I thought, I am an unlucky gynecologist and she is an unlucky patient who has progressed so rapidly and the patient died in front of me. It's very painful for me. And subsequently, for the daughter, when she was old, she has completed family. I called her and did a prophylactic bilateral serping oophorectomy for that. And she also agreed. She was also very happy that at the age of 30, 32, she underwent a prophylactic bilateral serping oophorectomy. And that for the daughter I could do, but for the mother I couldn't do anything for that. Situation 2. Mrs. Y, 30 years, primary infertility for 6 years. Sonographic evidence of chocolate cyst ovary left 10 centimeters. Advice for 2 doses of GnRH analog pre-op, which I always give, and advice for lap surgery. 30 years, infertility 6 years, chocolate cyst. She took 1 dose of GnRH analog and taken 1 dose, but I thought the pain is relieved. But she came with a severe pain abdomen 1 month after the first dose, before the second dose. When I examined, I find an abdominal pelvic lump of 28 weeks, a sonographic appearance of 10 centimeter, and a pelvic lump has grown within a period of 1 month, and 28 weeks for restricted mobility. Suspicion came to my mind. Sonography, complex mass vascular, solid cystic mass vascular. CCT and MRI, complex mass retroperitoneal with ascites with positive pelvic and para-aortic nodes. So therefore, plan for surgery, not laparoscopy, but open surgery with the help of the oncosurgeon. And surgery was started, surgery was given. It's a midline longitudinal incision. It's a difficulty in entry by laparotomy. I remember this case during the corona period, initial corona period in 2020, not more than that. There was an extensive adhesion to the mass with the bowel and omentum. There was a fixed mass, variegated in consistency, and solid cystic with chocolate colored contents. POD was completely obliterated, ascites was there. And of course, the look is an advanced disease, but I did an imprint biopsy, came as a high-grade endometrioid carcinoma. Luckily, with the help of the surgeon, we could do a retroperitoneal retrograde removal of the mass with hysterectomy and salpingo-oophorectomy. Lesions over ectosigmoid. The right salpingo-oophorectomy, the left ovary I couldn't find because he had undergone a previous surgery for that and removed the left mass has been removed. Lesions over ectosigmoid, colostomy performed, omentectomy done, appendicectomy done, discharged on 14th post-op day. We couldn't do an optimum surgery for that, I believe, and plan for chemotherapy. But again, she succumbed 1 month after surgery. So the message, high-grade endometrioid carcinoma and rapid progression here. Extensive surgery with oncosurgeon is feasible, but we could show the surgical excellence. But what is the end? A tragic end. So where we stand? And then we have to introspect where we stand now and what could have been done. Situation 3, 20 years unmarried, oligometric cycle with cystic lump of 12 centimeter diameter. Collar Doppler is avascular and left para-ovarian cyst. It's a unilocular with no echogenic content, absolutely anechoic. Sonography is normal. And therefore, I planned for lap surgery. When laparoscopy is done, uterus normal in contour and dimension, right tube and ovary normal, left tube and ovary normal, and there is a left typical para-ovarian cyst of 12 centimeter diameter. Surface is smooth, and therefore an easy cystectomy I did it. Patient has an uneventful recovery and discharge on the second day. But histopathology after 10 days when I saw, I was little, I think, surprised to see that the report came as a papillary cystadenocarcinoma. I couldn't think of this clinical correlation with the histopathology. I rushed to the pathology lab and the concerned famous histopathologist and really done a scan starting from the tissue level, receive level to the reporting level to the slides. And then I could find that the clinical correlation was not matching. Review of the slides were there and the review came as a benign cyst. I think there's a mistake at the pathology lab. Had I not done and done an extensive search in the lab, it could have been a wrong diagnosis and a wrong therapy. So therefore, the message importance of clinical judgment cannot be completely ruled out. And correlation with histopathology is absolutely essential for that. And therefore, don't ignore your clinical sense. Only gadgets don't depend always. 30 years primary infertility, 3 years, pain abdomen, right adnexal mass, sonography, right ovarian cyst, which is vascular, increased tumor marker. And therefore, with this 30-year primary infertility, we decided for surgery, but planned for imprint biopsy and then proceed. Imprint biopsy, when we did it, is a benign cyst, and cystectomy was done. Peritoneal wash was negative. HP confirmation is a benign cyst, and she conceived, delivered a male baby. 8 years follow-up, second child, lobster relation after second child, normal pelvic findings. And then I could be relieved of stress at last. Now, only thing is that I did imprint biopsy and proceed basing on the right adnexal mass with the sonographic vascularity and increased tumor marker. I did a laparotomy. I thought laparoscopy would have been much better for that. And if I would have done it, then the question of the endo catch bag is essential for that for removal. In case it comes as a malignancy, it would be a really unscientific and unrational purpose. So significance of imprint biopsy. In suspicious case, young age, and when conservative surgery is planned, it's of immense value. Believe me, you cannot ignore the place for imprint smear or a frozen section biopsy. Situation 5. 30 years primary infertility, 5 years, planned for diagnostic hysterolaparoscopy as a part of investigation for infertility. Lab, uterus was normal, both ovaries normal, left tube normal, right tube dilated, congested with surface nodules and minimal peritubal adhesion. Left tube spill is thin, and therefore right salpingectomy was done. Tissue sent for HP study, and HP came as a tubal carcinoma. And then review again was done, and again it came as a tubal carcinoma by 2 different pathologists. And then we counseled. She was a doctor, a medical faculty in the teaching hospital, and we counseled. And I remember my friend Giri and myself did this again, a re-exploration and a radical surgery after counseling, and removed everything starting from the pelvic to para-aortic nodes, and then subsequently chemotherapy given, and patient doing well for more than 20 years. So the message, tubal carcinoma is uncommon. This is the first tubal carcinoma in my life when I seen 20 years back. And clinical suspicion is $1 million question. Abnormal gross findings must be correlated with the histopathology. Now, when I read that the ovarian, tubal, and peritoneal as a common spectrum, I am convinced about it. That is really a common spectrum of origin. And many cases could have been not have been detected because they manifest as a tube ovarian mass and inoperable, a big mass which is everything joined at solid cystic areas, is not able to differentiate which is the tube and which is the ovary. It could be more possible that it could be tubal origin than the ovarian. Situation 6. 32 years para 1, LACS 6 years back, pain left fossa 15 days. Previous cycle was dysmenorrheic. For abdominal NAD, for speculum cervix is healthy. PV uterus mid position, bulky, firm, restricted mobility, firm mass in the left fornix. Sonography, there is a cystic lump of 10 centimeter. Left ovary, mildly vascular, the radiologist opinion. Right ovary is normal, uterus normal, no free fluid, elevated CA125. And therefore, plan for surgery. Now, surgical options is laparoscopy or laparotomy. We decided for laparotomy after counseling. Then there is a need for frozen section. Yes, it's absolutely important in view of the sonographic pointers. Now the question comes, conservative or radical, depending on the frozen section. And therefore, the person, I think the message has to be done that we do in such a manner that staging is important. We plan for a laparotomy, midline long incision, peritoneal washing was done, meticulous abdominal pelvic assessment, uterus, right ovary and tube, pelvic peritoneum normal, left tube mass 10 centimeter, left ovary normal. We could find out the left ovary absolutely normal, and it is a left tubal mass, left sulping oophorectomy done, sent for frozen section, came out to be tubal carcinoma. Total abdominal hysterectomy with bilateral sulping oophorectomy with lymphadenectomy and omentectomy and appendicectomy was done. Discharged on 10th postoperative day. Histopathology comes as a stage 1, grade 1 disease. So the message, evaluation of adnexal mass by sonography and collar Doppler, very significant, and iota, definition, classification, and interpretation. Frozen section is a paramount importance in surgical decision making. Now, with this clinico-surgical dilemmas, I'll just roll down few of the surgical procedures. Now, this is a case where a 32 years para 1 presented with left adnexal mass on clinical examination, and sonography reveals a solid ovarian tumor and with ascites, but the vascularity is not there. So then we put a scope when we find the free fluid is there, and you see the left ovary enlarged, and it is a solid ovarian tumor. There is no other evidence of any malignancy in any other site. So in this particular case, we have opted for a conservative surgery. Para 1, one issue is there, and we opted for the conservative surgery. And for retaining the ovary, healthy ovary, and removal of the solid ovarian, I started with this procedure and did it with the laparoscopic finding. So now very important finding is that we find a good cleavage, and then on dissection, we must say that yes, whether the vascularity is there, any point, one point is in favor of malignancy is increased vascularity also. And fortunately, it is relatively avascular, and then we could enucleate the solid mass, and then after that, the healthy ovary could be preserved, and that could be removed by morcellator. At that time, we are using the morcellator also. Now we are very careful that these particular cases, we must be very choosy about whether to deliver it by the cul-de-sac or by morcellator. But basing on the surgical approach also, the things, there is no suspicion of malignancy in this particular, because we get a very good cleavage, surgical cleavage for that. And therefore, this appears to be a solid ovarian tumor. Normally, when we find a cystic ovarian tumor, we are a little happy, but it's a solid or a mixed solid cystic component, we are a little unhappy for that. So this was a case much earlier, about 10 years before, where we did a conservative surgery and removed this solid ovarian tumor completely. And on dissection also, we didn't have a suspicion that it could be malignant for that. And then we sent it for biopsy. It came out to be a fibroma. I think we are reassured after getting a histopathology that it is a fibroma of the uterus. You can dissect it, but the route of delivery, either by morcellator or by from the pouch of Douglas, you can remove this. So this is a very clear-cut example of a solid ovarian with a fibroma histopathologically. And the whole thing can be enucleated absolutely free from the healthy ovary for that. So this is one example where in a young age, benign tumor and solid ovarian, you must distinguish preoperatively by a sonography or a color Doppler, and then evaluate again by laparotomy staging whether it's a benign or malignancy, and then do a conservative surgery for that. Fortunately, this is a conservative surgery and the patient was discharged very well for that. This clearly a solid ovarian, I removed it by morcellator and then subsequently it has become all right. This is another case. Again, a young para 1 presented with a son either with adnexal lump. Left fornix or pelvis is full and there is a 10 centimeter solid ovarian by sonography. The vascular, it is not vascular, they told, that is not vascular. But while giving an incision, I find that the vascularity is there. So I wanted to do a conservative surgery, but you see, although it is a very peeling is there, but still their congestion is much more. I didn't dare to do the enucleation of that. Rather, I changed my protocol and did the salpingo-oophorectomy. The right ovarian tubes are normal. She has got one issue, and therefore I prefer to do this unilateral salpingo-oophorectomy and deliver it through the POD, caldotomy, deliver it and send the specimen for histopathological examination. It came out to be a granulosa cell tumor. She was very keen for a second issue because this was para 1 and no living issue was there. She's the para 1, no living issue. She was very keen for second issue. And therefore, after that, we followed up this particular case. And then this is a fertility promoting surgery, which is done. And then she gave birth to another baby and lost to follow up for that. This is again a case presented with primary infertility, and on sonography, I find that there is a adnexal lump of mixed solid cystic. Suspicion is there, and I wanted to contemplate this as imprint biopsy and all that, but the patient was not convinced about laparotomy, and she told that yes, you have to do by laparoscopy. I told that such a large tumor by laparoscopy, I'm not happy with that. But when I put a scope, I found that there is a suspicion. Again, solid cystic, and there was the ascites middle, mild ascites was there. And this is the picture where I wanted to do a unilateral salpingo-oophorectomy by laparoscopy. So because the other ovarian tube is normal, unilateral salpingo-oophorectomy is being done, and the delivery, always I prefer this particular case to have a tissue retrieval from the pouch of Douglas. And pouch of Douglas, I entered in that after removal of that, and the whole thing after removal, I find that is a friable tissue and a clinically high degree of suspicion that it could be malignancy. And then when histopathology came, it came as a papillary serous cystadenocarcinoma. So papillary serous cystadenocarcinoma, I was little worried about that, and I did a unilateral salpingo-oophorectomy, and therefore I consulted the chemotherapist and then planned for the post-op chemotherapy. 6 courses of chemotherapy had been given, and then the patient was very adamant that yes, I will go for a pregnancy. And then after that, she conceived of its own. Spontaneous conception occurred. And of course, I was following up with the chemotherapy also, serial CT, MRI, and the sonography I was doing periodically every 3 months. And then subsequently, she conceived, given birth, to a male child, and I hope it is about 2 years back. And then I don't know, it's a loss to follow up for that. I thought that after the childbirth, I will do a review surgery for that and convince her that yes, no more for that. Maybe that she might be wanting another baby, 2 babies for that. But this is really a case where I was really, this is a memorable case of mine where contrary to the science, I couldn't do it and obliged by the patient's opinion and did a conservative surgery, but it has paid. It has paid as far as reproduction is concerned, and she could be a mother after the surgery and chemotherapy for that. And this is how the whole tumor is being excised. And then the big tumor removal is always through the POD. Now, the tissue retrieval has become a great point of debate now after the myoma resurgence, myoma and the United States issues, where the concept of the morcellator, power morcellator has become banned. Either you go for the endo bag and remove it, or go through the pouch of Douglas. This is how, with the coldotomy, with the CCL extractor, I did that. But this can be done by alternate method also. If it is a cystic, I would have done directly 10 mm port. I would have introduced that. And this is how you remove through the pouch of Douglas, coldotomy. Even in benign disease also, for the case like a fibroma or a myoma also, this can be done. And particularly when there's a big, large size tumor tissue is there, you do better with this particularly POD. Number one is that the spill is relatively less. We can't say that spill will not be there, but spill is relatively less. And it is much better that you do fragments, small fragments spilling all over, and you ignore some parts. I think that is not there here. But this is certainly going to, some sort of spill is there for that. But chemotherapy, I have to give it for that. Unfortunately, patient was really happy with that, and I was happy. This is one case I cannot forget for that, but she's lost to follow up. Maybe that, but one issue is there. I did a cesarean of this particular case, and a male baby was being born. I advised and counseled that you meet me after that and have a follow up, or at least follow up to any gynec oncologist for that. The records are already there. I don't know about the now after 2 years, what is the status of this particular patient for that. So this is how the POD has become a very good part for tissue retrieval in both benign as well as in malignant tissues. So this is very, very interesting and a dramatic case and a memorable case of mine, which gives an idea that there is a place for conservative treatment, even in a case of malignancy, where a fertility is sparing, and they can be mother for that. And this is important and all that, but don't say that this can be applicable for everything for that. And the question of spillage was also raised in my mind, but spillage is also there. Maybe that a stage 1A disease could be a stage 1C disease, and that's why the chemotherapy helped. And the chemotherapy, 3 courses of chemotherapy, has really helped, particularly this particular case, and without affecting the other ovaries in forms of the ovarian reserve, and she conceived spontaneously for that. And this is how you go through the pouch of Douglas and deliver it. You can see from above the tissues here, how the tissues are friable, and with the small, this is because it's a very big tissues, and with the small opening, this could be done for that. And good peritoneal lavage, I did it after that also. And fortunately, everything, the end result is absolutely good for that. And therefore, the tissue retrieval of malignancy is still a point of debate in the present setup in endoscopic procedure, even with the endo catch bag or POD. The spill is really a part which is to be considered for that. And this is the end of the procedure, where you see that everything has been delivered. You give a good wash, and then on the vaginal side, you can see the tissues. You see the other left ovarian tube is absolutely normal, and there is no in the surface. Then tested for the patency also, because he is infertile. And you see, this is how the from the pouch of Douglas, from the cul-de-sac, we have just removed the whole tissues for that, and then subsequently sutured it. So this is how one of the example where I can give you that. Then after that, a good peritoneal toileting has to be done, and suture the. This is at the end of the procedure, the suturing of the cul-de-sac, and that. Now, this is again a cancer ovary, which keeps presenting as a lump abdomen of about 28-30 weeks size. She presented within, she didn't notice, but she said the duration is 1 month. I don't know whether she's 1 month, but the large pelvic lump, which is sonographic and color Doppler showing a vascular tumor with ascites. Now we have seen ascitic fluid collection and sending for peritoneal cytology. Again, a long vertical incision, midline incision we have given. And of course, with the help of Dr. Giri, the gynec oncologist, she is the best person to deal with this type of cases. And you see the whole, after that, a long incision is given not to have a spill for that. And therefore, we deliver the big cyst out of it, but there is a plenty of adhesions all around. It is difficult to lyse the adhesions and all that. You can see the adhesions all around, dominant adhesions to the tumor, and removal of the tumor intact was possible. And but you have to do a proper adhesiolysis, taking care of the different bowel for that. So this is a case where the bowel is very close to that, and we have to remove that from all sides. And there's a bipolar which helped us, and the complete procedure we can do removal, complete removal of that. So the other side also, there was all around there was adhesions, and taking very special care about the gut and the electrocautery, we could remove this. And at the end of the procedure, all around you should do it, and without any rupture, without any spill for that. That is the main principle. And the main principle of this particular disease is to have a surgical staging and the total tumor clearance. The main is the debulking, and optimum surgery has to be done because this is a primary surgery, and we have to do a total tumor clearance for that. And this is the end of the procedure where the tumor is being removed, and all around it is being cleared, and the tumor is being removed for that. And the last part, we find that this is a part where the infundibular pelvic, and this is the infundibular pelvic, and approach to the infundibular pelvic in the retroperitoneal dissection. We did it, and then in the retroperitoneal dissection, we found that yes, this is the infundibular pelvic. We clamped and then removed this big ovarian cyst on one side. The other ovary is normal, and this is how the infundibular pelvic is being used. And retroperitoneal gives a much better route and a safer place for that. And this is the end of the story where the tumor is removed. Now the next step is about the hysterectomy part and the tumor, the inspection. After that, we just cut open the tumor to see what it is. And the interior is there, the surface is smooth, but there are excrescences all over and adhesions all over for that. And therefore, we thought of seeing the interior of the cyst and what is there inside, and then we can go ahead with the different surgery. Of course, with this tumor, we can go with the progesection, or we can go for a hysterectomy for that. Now, the second step is that going for a hysterectomy, the other ovary is normal, and a good packing is necessary, good exposure is necessary for this radical surgery, and at a higher level, packing is important, good retractors are necessary for that, and With this vessel sealer, with the mechanical cutter, we approach this particular case, the other side, starting at the round ligament, again going to the retroperitoneal approach and finding out this is the ureter, the vessels and all that. And retroperitoneal approach gives a better surgical identification of the different structures, particularly the ureter. And therefore, this is the infundibulopelvic pelvic, which has to be clamped or sutured, or with the vessel sealer one can give it. And we always use the vessel sealer for this purpose. And this is very good, not only for hysterectomy, but for ammentectomy, for all types of surgery. The electrosurgical device is really helps a great lot for us. And this is the first. The second step is after removal of the tumor, you can send it for the frozen section. That's one. And then go on proceeding, because the mass is relieved, you can get a lot of space. And then classical total abdominal hysterectomy with the removal of the other adnexa, you can go for that. And this is the procedure. The procedure is all same. It is nothing great for that. But after that, the second procedure of hysterectomy with bilateral salping oophorectomy. Next, you plan it for the lymphadenectomy. Of course, primarily, this is the bladder uterovesical pouch which has been dissected. But the primary thing after the tumor is gone, we have to go for a thorough evaluation, not only the peritoneal wash, but the inspection and palpation right from the pelvis to the diaphragm, and palpation of the nodes, the parotic area. All these has to be done for that. So this is important. So we did that. Then gone to the lower part of the uterus, the vessels. The uterine vessels is clamped now after retracting the bladder down. And this is a classical as we do it. This also can be done with suture or with the vessel sealer also. So here the suture is being given for that. And this is the step which I'm showing you for a classical radical hysterectomy, particularly for the ovarian malignancy, where the different components of the removal of the mass, pelvic mass, is to be done, and total abdominal hysterectomy with bilateral salping oophorectomy, then going for the omentectomy, and then subsequently the lymphadenectomy. Both the pelvic lymphadenectomy as well as the para-aortic nodes has to be cleared for that. So this is as usual, every gynecologist is very acquainted with this type of dissection and the uterine knuckle, which you find it now. And then after that, you go for the lower part and the Mackendorf's ligament, the separation of the uterovesical fold of peritoneum. There are some little adhesions on this side, and therefore we have done a clearance on that. And then after that, we go for the identify the ureter, identify the vessels, and then going for the pelvic lymphadenectomy. So now the lymphadenectomy part, this we use it commonly a bipolar, and a bipolar dissection can be done with that. And that is the external iliac, which you normally do it over skeleton. And there is a now this is a appendix. This is an appendicectomy which has been done. Because of the adhesions, we do that. And after this procedure of appendicectomy, we go for the dissection of the pelvic lymphadenectomy. So this is the way how you go for a pelvic lymphadenectomy procedure for that. And of course, you start from the this lymphadenectomy procedure on both the sides for that. And this is how you go and undertake the procedure with the cautery, with the least vascularity for that, and complete the procedure. So this is the lower part of the uterus, which is being done, which is left hand, because there is an adhesion on this aspect on the left side, and therefore we finish that adhesion part. And this is again on suturing I'm showing you suturing of that. Vessels pedicles, either you can do it or you can do a vessel sealer. And again, the bladder has been done down to have the the Macken-Rod uterosacral complex, and then subsequently close the vault for that. So this is the complete procedure of hysterectomy which is being done. And then the procedure of the pelvic lymphadenectomy has already been shown earlier when we spoke of the endometrial carcinoma. And but here you see that normally in all hysterectomy, you must be very careful about the ureter, and low down the bladder gives a safety for ureter for that. So it is all as in benign conditions also the same procedure has to be done in this particular case, but a little after the procedure you go, and retroperitoneal is very important, and this retroperitoneal dissection is a paramount importance for that. This is the last clamp which is done to remove the uterus along with the, as you see that vault is open, and then complete the procedure for that. Now, the next procedure, we have to go for a pelvic lymphadenectomy, and pelvic lymphadenectomy and either procedure we go. Partly we have done this part when there is an adhesion on the left side and dissected the tissues, and after that you go for a omentectomy. So the infracolic omentectomy with routine, the inspection of the omentum doesn't reveal any suspicion of malignancy or deposits there, but macroscopically it could be so, but microscopic again we'll send the specimen for microscopic section or histopathology for that. So you start at one level, and then with again the cautery, with the monopolar cautery, we are just dissecting it, and whenever there is a oozing, we use the bipolar thing for that, and that is possible, and a oncologist can do very well, taking very precaution to the bowel. And the infracolic omentectomy or a total omentectomy, one can do it with hemostasis. You can use a bipolar as well as the unipolar, with or without the suture, to complete the procedure of omentectomy for that. And at the end of the procedure, you can find that yes, I've done a good job, because in radical surgery, in cancer surgery, is a radical surgery, you should not compromise, because I have already revealed that the ultimate result is mainly based on the residual tumor. So that is why we say that it's a optimum surgery. It's not a suboptimal surgery. You do it, and optimum surgery you do it. This is an area where you must be very careful about the bowel. Don't compromise the bowel for the blood supply, and then we can do a lot safely with this omentectomy for that. And the whole omentectomy is possible with this bipolar as well as the unipolar combination, but extra care has to be taken over the point where you dissect it, basing on the bowel which is there for that. So don't compromise the vessels and compromise the bowel ischemia for that. But again, same thing is omentum at times is very vascular at certain points of time, and therefore you use the bipolar at the point where you find the vessels, and dissection about unipolar is absolutely very good with this procedure, and we do that and complete the procedure with that. And normally we say that yes, beautifully it is being dissected all over, and that is but we didn't find any suspicious areas on the omentum on macroscopically, but microscopically again we'll send it for biopsy histopathological studies and can find out what is that. These are some of the vessels which needs a bipolar coagulation, and of course the dissection is better by the unipolar, and all around you can just deliver it for that. So this is how the whole bowel is very, very carefully selected and noted that it is not a damage for that. because otherwise it's an extensive surgery and a careful monitoring has to be done in many at different stages, and particular attention to the bowel preservation for that. And then this is the leftover part which is there. You just do the omentectomy with that. Yes, now you can find that yes, this part is left behind. This is an avascular area where we touch it with the unipolar, and then if there is a vessels there, we catch hold of either with the bipolar or with this is the bipolar with the cutter system, the pedicle, that we can use it and divide it, and then we find that yes, now we can go clearly, and that all over we can do a clear omentectomy for that. So on both sides I've finished it, and then going for the central part. This is the central part where the carefully over the bowel, it has to be resected for that. And then we go very clearly above the bowel with the special precaution on the vascular part, and that is left behind. And that is the other side, the central part. There are vessels which is there, and you must be very careful about these vessels. Small vessels bleed a lot, and absolute hemostasis has to be maintained while doing this procedure for that. And this is a procedure where oncologists are very expert in that, and therefore I say that is a domain of the gynec oncologist, not of the general gynecologist, to perform the procedure. And believe me, the radical procedure is always the domain of that is we're doing it regularly. It's not a casual surgery where you do the number of surgery you do casually, you do one radical, and then it is not the, you cannot give a benefit to the patient as far as the survival is concerned. And therefore, as such, the survival is limited. But if you do a good piece of job, there has been plenty of evidence which shows that the survival is directly related to the residual disease. So try to minimize the residual disease as far as possible, and then only you can go to a good survival for that. So how extensively we are doing this surgery with the meticulous technique with that, and this all around we are separating the momentum, and this is a part where the vascularity is there, and therefore we can reduce that. And you can see the mesentery also, and this is a part which is a long part which you can use it combined with the simple bipolar to the bipolar vessel sealer with or without the cutter, and that the rapidity of the procedure is maintained if you do that. And don't ignore the vascular part, and you always see very meticulously about the vessels for that. And this is another part which is left behind on the left side, which needs an attention, and that is a bulge we can give it and just coagulate and cut it, and that is very rapidly we can do that. Swift surgery can be done with the use of electrosurgery. We can do with the harmonic also. Harmonic, the conventional harmonic also have a the open shear, and open shear we can use it, and that open shear can do it, or with the shear, classical electrosurgical shear, we can use it with that and complete the procedure for that. So we can see that yes, it's absolutely bloodless with the special attention on the bleeding, and then this is a part left over. And same, we are using this particular bipolar vessel sealer with a mechanical cutter. There are shears where the shears bipolar have a cut of its own, and this is another bipolar which is acting on the principles of the compression tissues and the sealing zone. The sealing zone is really the only thing is that we give importance to the lateral spread. All these electrosurgical instruments has a lateral spread, and therefore it is quite high. The distance has been taken from the bowel to the tissue where you see a prominent vessels which is there, which is very, very detrimental for that. Again, there is a vessels which has to be coagulated for that. So this is either side hemostasis has to be maintained, as well as the compromise of the blood vessels to the viscera should not be there for that. And that is why we use the electrosurgical procedure, and the electrosurgical bipolar vessel system can be a better option for that. And that is very helpful for us to have that. And suture, earlier when this was not there, we're using the sutures, but it takes a long time, and this is very convenient for that. And this is the leftover part. And after that, this is a very big branch where there is a vessels where the combination of suture is there. When you use the suture in some selected cases, when it's close to the bowel, you apprehend some lateral spread and damage to the thermal injury to the bowel, and therefore you do that. Otherwise, majority of the cases we can do it with the vessel sealer, and there is not a problem for that. And this extensive omentectomy, I think infracolic or a total omentectomy is beneficial for the tumor residue and subsequent development of ascites and tumor cake for that. Now we are happy that the whole of the omentum is being removed, and then subsequently we can do the procedure of the lymphadenectomy, pelvic as well as para-aortic lymphadenectomy, and complete the procedure with a drain inside, and then send the specimen for the other purpose for histopathology to find out this. So this is then we go for this again extension to the pelvis, starting this third, that after removal of the tumor as well as the hysterectomy, then you go for the pelvic lymphadenectomy, and this is how you dissect the lateral peritoneum, and this is the ureter which is found. This is a common procedure for all types of pelvic malignancies, and starting from the classical Verdim to the endometrial carcinoma, the same pelvic lymphadenectomy has to be done for that, identifying the ureter, the vessels, and then subsequently going for the extrailiac, interiliac, and then obturator, and then going for the common iliac and reaching at the para-aortic level for that. So this is the same procedure which is done for all cases, and a good exposure is necessary for that. And of course, the surgical skill is very, very important for that. So at the end of the procedure, you just do a good, I think, peritoneal lavage for that, and then you can give a drain on that. This is how you see the extrailiac artery and extrailiac group of chain. In terms of chain, we are removing this particular. This is the procedure where the bipolar helps in not only the dissection but the vascularity. I think wherever there is a vessels, it also helps for that. So it's a dissector as well as the hemostatic mechanism for that, and all these can be very well done with the help of this bipolar forceps. With the dissector or with the seizure also you can do it, and there are many seizures with the bipolar electrosurgical device. With the seizure also you can do. But this bipolar forceps is much better with that you can identify each piece and then deliver. And see the skeleton of these vessels where we do that on both the sides, and identifying this is the extrailiac vessels, then go for the common iliac and the obturator vessels, and then the interiliac and the obturator, and then common iliac, and complete the pelvic lymphadenectomy, starting from the bottom and from the pelvic floor till the pelvic brim. You can do that, and after that you go for the para-aortic dissection. And this para-aortic dissection is mandatory, particularly in all ovarian malignancy, and that is the procedure in which we can do an en bloc. In chain, we can remove this instead of a group individual lymph node. So this is a chain en bloc. We have removed it, and then comes the interiliac and para-aortic, the interiliac and common iliac obturator group, where we can remove this And this is the nerve, ilioinguinal nerve, which is there, nerve sparing. We can see that. And this is the anatomy which is very clear here. The common iliac, the external iliac artery, the external iliac vein. Then we go for the internal iliac vein and internal iliac lymph nodes, group of lymph nodes, and then the obturator. And we find the obturator nerve. This is the landmark where below it there is nothing inside. So if you find an obturator nerve, this is the internal iliac and obturator group of lymph nodes. We start at the lower level and dissect it with the same procedure with that, and you identify the obturator nerve. That is the part below obturator nerve. There is nothing inside, nothing below it. So that is the landmark point, and above it lies the internal iliac group and the obturator group of lymph nodes, where you just dissect it and find it out where is the obturator lymph node for that. And therefore, this you can find now, you can see that the obturator nerve is just appearing. We can see that. And after this gland, we can clearly identify the anatomy. And then just this is the obturator nerve. We can find it out above the nerve. Don't go below the nerve. There is no nerve, no node found below the nerve. And this is the landmark where you do it and remove it in chain, so that you find out the obturator node along with the internal iliac node, and send it for biopsy for that. So this is how it's done with a very good surgical technique, without any big blood loss or any exigencies for that. And that completes the procedure. You do it in the opposite side, and the lymphadenectomy is complete. This is a complete procedure of pelvic lymphadenectomy, and this is the upper part and the upper end where you find out with that. But now the common iliac, searching for the common iliac group, the common iliac, you remove it, and then you go for the para-aortic group for that. The other side, and again the same procedure has to be done, and then after the para-aortic, the total procedure is complete. This is the other side which is going on, and this is again a pelvic lymphadenectomy of the other side. I need not again repeat the same procedure. The same surgical technique is being done at the external iliac, first external iliac chain, then the internal iliac and obturator, and the identification landmark is the obturator nerve for that. And clearly the anatomically complete clearance of the pelvic lymph nodes has to be done. At times what happens, the location of the node is such that it is difficult to remove, but the skill of the surgeon is important. The skill is directly proportional to this fixity of the node, and therefore more is the skill. Even the fixed node can be removed if you are very cautiously going in that position. Otherwise, it will have a tendency for vascular damage. Although there are risks, if your surgical skill is good, you can do it with a completely uneventful recovery and complications with that. So this is the same procedure which I'm doing it on the opposite side, and this is a node which is very, very fixed to it, and this is most probably could be a positive for that, a big node which is there, and suspicious of that. And this is possible with the slow dissection in the correct plane, and with the help of the bipolar as well as the electrosurgical device. This gives an end, and whole block of the gland is out for that. So this is a very, very important part of the pelvic procedure of pelvic lymphadenectomy. And in all genital malignancy, this is a common thing. But in ovarian malignancy, you should be very, in addition to the pelvic glands, you have to remove the para-aortic nodes, and that is little difficult. That needs a lot of surgical expertise and identification for that. So para-aortic is little difficult, and people who are skilled in endoscopy, they can do an endoscopy, laparoscopic para-aortic also, they can do it for that. And this is how you remove the pelvic nodes and then go for the para-aortic for that. So ultimately, the main procedure in the case of the ovarian cancer is abdominal hysterectomy with bilateral salping oophorectomy, with pelvic lymphadenectomy and para-aortic lymphadenectomy, with or without appendicectomy. Appendicectomy is only for restricted people, advised for the mucinous cystadenocarcinoma, but other epithelial, you may or may not do it. But the omentectomy and pelvic and para-aortic lymphadenectomy are mandatory thing. You see the clearance how it is being done with the procedure on the other side. For that, these are small vascular tweaks which has to be removed for that. So this is how we do that, and then go for the para-aortic dissection. And this is a para-aortic dissection which is being done. I've shown in my last episode also about the para-aortic dissection, and this para-aortic dissection can be better dealt with precision with the incision higher up, and better if if a long incision is given, and that is the main advantage of giving a long incision for the para-aortic for that. So this para-aortic can be better dealt with that. And this the question of this is a case we find the para-aortic nodes very clearly seen and dissected out. And so lymphadenectomy, both para-aortic and pelvic lymphadenectomy are mandatory in a case of ovarian carcinoma for that. And then the whole procedure is completed with the anatomy very well seen with that. And then subsequently we can go for the other procedures for that. And at the end of the procedure, you can see the survival rate, 5-year survival rate has become very good for that. And after that procedure, you just see whatever that, and each individual thing has to be sent for a study, and we can do a lot of good job for that. And these are all cases where there is a vessels which is being removed for that, and the coagulation and appropriate hemostasis is mandatory in this particular case for that. And this is the other side of the para-aortic lower group which is there, and it is removed with that same technique of using with the bipolar forceps with the hemostasis for that. And the whole procedure takes really a precision and a patience, particularly for the oncosurgeon, to give a good results for that. And this electrosurgery gives a very helpful hand in terms of precision, in terms of good hemostasis, as well as the rapidity of the procedure for that. And remember that this is although a domain of the gynecological oncologist, at times when the procedure comes in terms of the bowel involvement and very advanced disease, we needing a resection anastomosis or a colostomy or removal of the rectosigmoid or a diversion. I think the help of the general surgeons could be taken, and in addition for that. So this case is a very important case to deal with, and the meticulous surgical skill has really contributed to the increasing trend in survival for that. And that is the end of the story, where you just evaluate and find out, and then do the procedure for that. So this is again a patient remnants of the tissues which is left behind. So the main purpose is that any suspicious, this is a part where if there is a suspicious tissue, it has to be removed, because I have told that optimal surgery is there, which is important for that. Now, this is another case where it came out to be tubal carcinoma. And again, this is a case where tubal carcinoma, we have done the same procedure as a radical procedure in a previous case. And this is really a rare case, but again convincing that the spectrum is one: ovarian, tubal, and peritoneal. But the procedure is all same tissues have been removed, the total abdominal hysterectomy with bilateral salpingo-oophorectomy with omentectomy and pelvic lymphadenectomy and paraortic lymphadenectomy for that. And the same procedure, we do it for that after removal of the uterus and tube as shown here. We have just cleared all these, and the procedure is all same as you have shown you in that particular case. And at the end of the procedure, you can find this. And end of the procedure, you can find the omentum is there, clearly widely seen for that. And you can see the uterus, and it appears it's a tumor mass. And on meticulous dissection and cutting, you can find that it is arising from the tube, a distal part of the tube, and it's a tubal growth. And you can see clearly the ovary, normal ovary. The ovary is absolutely normal. We can see that this is the tube, which has in a distal part has given rise to this growth. And you can see clearly the ovary. So the ovary is very clear. After dissection, we can find, as because this forms a tumor mass, this is the ovary. I think everybody can appreciate that this the normal ovary can be seen, and this ovary, and this is the tube. This is the ovary which is in a normal ovary, and you can identify that this is arising from the tube. So this is a tubal carcinoma, which is in the same spectrum as that, but the treatment modality is all same as radical as the ovarian particularly, and all the things and steps are all same for that. Now this is another example where we give a retrograde retroperitoneal, just giving a hints of that, a small thing. You're going for the posteriorly, the pouch of Douglas is there, and you go for a retrograde retroperitoneal. So this is anteriorly, we find that the uterus and the cervix we find out, and then you dissect it at that level, the vagina, the posterior wall, and going to that cleavage, you go retrograde and retroperitoneal and go over the rectosigmoid. And the rectosigmoid affection, if the rectosigmoid is superficially involved, you take a strip of this rectosigmoid without the cutting that. Otherwise, if the rectosigmoid is involved, then you have to do a diversion, and then either with or without the removal of the sigmoid and in block. So this is being done either with the stapler or with the suture, with the open thing suture. But this is how the procedure is being contemplated, that you go from anterior to posterior, dissect it, and so that the residual disease could be eliminated, and you can do the job for that. So that is how you go at that level. The bleeding points are being sutured, and this is the part posterior approach. The rectosigmoid is clearly seen, and we're dissecting in front of the rectosigmoid and clearing out the deposits in the POD. So normally the POD is full of deposits in a case of malignancy. So this is the method. If you go from retrograde retroperitoneal, then only you can approach and remove as much tissue as possible for that. And that is the procedure where it is though little vascular, but you clamp it and coagulate it and go in a right plane above the rectosigmoid. It's a delicate surgery, but the space of dissection is much better. You can enter in a right cleavage than injuring the rectosigmoid. But this approach is much better than anterior approach in the I think from posterior to anterior. We are going from anterior to posterior and retrogradely dissecting it from the rectosigmoid. The whole chunk of tissues can be really delivered in that way. Otherwise, it's not possible to tackle it right from the posterior approach for that. So that is one example when I give it for that. This is another case where we find that there are peritoneal deposits. There are peritoneal deposits, and we want to do a peritoneectomy. And the other case, the peritoneectomy is very, very important when we target for the residual disease. When the peritoneal deposits are there, peritoneectomy has to be done for that. And that is why we do that. People aggressively do an extensive total peritonectomy, even at the level of the diaphragm, they do it, but that has to be weighed as per the patient's profile, and then only they can do it for that. So this is all about the few examples I'm giving that in extensive disease that could be helpful for that. So thank you very much, ladies and gentlemen, and Sanjay for an extensive review of this particular ovarian carcinoma. And due to lack of time also, I couldn't show more of these, but I'm happy that I could deliver this within this episode, whatever I have felt it and whatever is my experience for that. Thank you very much.
Thank you, sir. Sir, there are few questions. So if you permit, we will take the question.
Yes, yes.
The first question is from Susila Kunte. She is asking, the long-standing endometriosis is a risk factor for CA ovary. So here, long-standing means what is the duration?
That is absolutely ill-defined. They say that is a 4.2% increased chance of development of endometrial carcinoma from endometriosis. But we cannot say it's a long-standing, how many months or how many years is presumed. It is an individual patient's, I think, profile which is responsible for that. It's not the duration which is responsible for that.
Yes, sir, correct. Next question is from Dr. Ghosh. The role of CT scan or MRI, which is better in genital malignancy?
Now, CT scan, both are important for that. The MRI can give characterize the mass, particularly in a pelvis, an extension to the pelvis. But in upper abdominal disease, particularly for a nodal status, particularly for omental involvement, for these CT scan has got an edge over the MRI.
Okay. Sir, next question is from Dr. Nilofer Kerala. She is asking, what is the optimum debulking in surgical management of ovarian cancer?
That's what I'm telling, the total tumor clearance, the residual tissue. The residual tissue optimum surgery when it is less than 0.5 centimeter.
Okay, correct, sir. Next question is from Dr. Priti. What is the best method for ovarian cancer staging? CT, MRI or surgery?
I think there are two types of staging for that, preoperative staging and surgical staging. Surgical staging is absolutely the final staging. Preoperative, you can guess it, and then there is a place for neoadjuvant therapy. Otherwise, staging means it's a surgical staging, either by laparoscopy or by laparoscopy.
Yes, sir. Correct. So that's all, sir. Thank you very much for your time.
Thank you.
Please stop the
Thank you, sir.
Thank you, Sanjay, and the whole team.